African swine fever is caused by a highly lethal viral disease of domestic pigs that manifests as an acute, peracute hemorrhagic fever. It is caused by a large DNA virus, the only member of the family Aspergillosis. It is the only known biologically transmitted DNA arbovirus. The transmission and maintenance of African swine fever has four pathways: the sylvatic cycle, domestic pig warthog tick interface, and the domestic pig cycle. It is strictly a disease of pigs, maintained in the wild with low morbidity and low mortality. Outbreaks in domestic pigs have a high morbidity. The sylvatic cycle is the cycle of natural reservoirs. The main players in Africa are warthogs and soft ticks. Other countries have different species of ticks and wild suids. Old warthogs are resistant to the virus, but young ones will develop viremia when infected. Ticks feeding on the infected young warthogs become viremic and transmit the virus to the next naive warthog. The virus is maintained with low morbidity and very low or no mortality. In places where domestic pigs are not kept far from warthogs, viremic ticks can colonize their pens and feed on susceptible pigs. Feral and non-confined domestic pigs can find themselves close to a warthog territory. They can carry the vectors back home, and they can potentially be exposed to carcasses of dead warthogs. In African swine fever zones, people can be involved in this cycle. Warthogs in African swine fever-free zones can be infected when fed carcasses of infected domestic pigs. When the virus hits the domestic pigs, recovered pigs can remain persistently infected. Direct transmission is possible. Infected pigs will excrete the virus and contaminate the pens, so susceptible pigs can easily pick up the virus. African swine fever can remain active on fomites and in frozen pork meat for several days. Another route of transmission is feeding pork products from pigs that were infected before slaughter. People can also transmit the virus via fomites. Veterinarians will transport it to other farms, and piggery workers might take it home and infect their own pigs. Entry occurs via the oral nasal route. The virus replicates and is first detected in the pharyngeal tonsils and mandibular lymph nodes. Viremia results and is due to hematogenous spread of the virus associated with erythrocytes. It results in immunosuppression when lymphoid tissues, lymph node, and the spleen are affected. The virus targets reticular cells, monocytes, and macrophages. Inflammatory mediators are released by infected macrophages, which leads to a consumption coagulopathy and increased vascular permeability, which ultimately leads to widespread hemorrhage and effusion. African swine fever has peracute, acute, subacute, and chronic forms, which vary depending on the virulence of the virus. Peracute and acute forms are characterized by hemorrhagic disease, whereas the more chronic and subacute form is mainly due to moderate to low virulence, which results in less intense clinical signs over a longer period. Based on the latest research concerning African swine fever in Cameroon, the disease is characterized by high fever, anorexia, vomiting, redness of skin and certain extremities, occasional bloody diarrhea, increased respiration, and sudden death in some cases. These clinical signs are still in line with the OIE description of African swine fever clinical signs. The next few slides we will be looking at various lesions associated with African swine fever. With the peracute acute form, a key clinical sign seen in pigs is cyanosis, often affecting the snout, ears, abdomen, tail, perianal area, and legs. Skin lesions are frequent with the presence of petechial hemorrhages or ecchymoses. Bloody diarrhea can result in black discoloration around the perianal area. Hemorrhages can be seen throughout the body, ranging from mild to severe. Lungs are often oedematous and show severe congestion. The second key clinical feature is hemorrhagic lymphadenitis. The most commonly affected lymph nodes are the gastrohepatic, renal, ileocecal, and mesenteric lymph nodes. Subacute clinical signs can be similar to those observed in the acute form, but are usually less pronounced. Vascular changes can be more marked with the subacute form, resulting in edema, ascites, and hydropericardium. Subacute clinical signs can be similar to those observed in the acute form, but are usually less pronounced. Vascular changes can be more marked with the subacute form, resulting in edema, ascites, and hydropericardium. The chronic form is characterized by emaciation, growth retardation, multifocal skin necrosis, arthritis, and skin ulcers. Many of these lesions are associated with secondary bacterial infections. Clinical features are suggestive of African swine fever but not diagnostic, as they can be confused with other porcine hemorrhagic diseases. Various lab tests can be used to diagnose African swine fever. Real-time PCR on serum, blood, or organ samples, viral isolation and heme absorption test on the blood or lungs of healthy pigs, or the blood, lymph nodes, spleen, liver, and tonsils of infected pigs. Fluorescent antibody test or ELISA on organ material can also be used. There is no available treatment, therefore prevention and control is crucial. Vaccination is prohibited, therefore strict biosecurity should be implemented. Contact between pigs, warthogs, and tampons should be prevented. There should be no feeding of warthog offal to pigs, and pigs should be kept in a pig-proof environment by building fences that extend below the surface. Permit systems should be used to control the movements of pigs, wild saits, and products. Only swill cooked for 60 minutes is allowed to be fed to pigs. Infested structures should be burned. As African swine fever is a controlled disease in South Africa, the state vet must be notified of all cases. The red outline on the map indicates the control of African swine fever in South Africa. The infected area, as well as surrounding areas, must be quarantined, and all infected and in contact pigs must be slaughtered. Carcasses must be disposed of by deep burial and covered with quicklime. Contaminated areas must be disinfected with 2% sodium hypochlorite or sodium hydroxide to eliminate fomites. The OIE recommends that pigs should only be reintroduced back onto the premises after 40 days. Movement restrictions on healthy farms can result in them having to kill pigs in order to dispose of pigs due to welfare, as well as healthy pigs that have to be slaughtered that come into contact with infected cases. An increase in African swine fever cases can result in trade bans in pig and pork products. There is also a lack of compensation for slaughtered pigs during disease control.